So, and we choose a bit of a provocative title for this, saying like understanding health inequalities through machine learning. But basically, what we want to do is to share a bit of what we did using a very, for many of you, very simple machine learning techniques to understand a bit more of the issues that we have in our region regarding health inequalities. So just a bit of context, we focus on cancer pathways, on cancer patients, and between 2019 and 2022, we saw a significantly high number of cancer referrals coming from the most deprived area in our catching, and it's one of the most deprived areas in the country indeed. Lung cancer referrals are, for example, 2 times higher in these communities. Other cancer like breast cancer, colorectal cancer, urology cancer are also higher in these deprived areas. And even more alarming for us was to see that many of these patients were not coming through the scanning programs or to referral by consultants, but many of them were coming through the emergency. So it was only after they came to emergency, maybe or more likely due to other reasons, that's how we figure out that they have a cancer. And this obviously it reflects these health inequalities that we have in our region. And I am assuming that you probably have something similar in your own context. So we wanted to understand a bit more about who is it, so that we can think about how can we improve this, how can we, who is these people that have been disadvantaged somehow, and how can we create the strategies, find leverage points so that we can improve either the access to service, but more important, the outcomes of their experience. So we developed a very simple model. I'm not going to explain too much about what clustering is, but we developed a very simple model using cluster techniques. We tried different algorithms, and the idea was to allow the machine learning algorithm to tell us. So could you find, this broad range of people, who are those that are more likely to come? And we will see that, although when we started with this very general brochure saying that, well, from most deprived areas, actually there are some interesting differences between these groups, actually help us to start thinking on how can we do things differently, especially in terms of access to our service. At the end, we did it for both for hospitals, or we have a hospital in North Essex, the Colchester Hospital, and a hospital in East Suffolk, that's Ipswich Hospital, and they cover very different demographics, despite the fact that they are not so far from each other. The people that live in these areas is very different. So the people that live in deprived areas in East Suffolk is very, very, very different from people that live in deprived areas in the north of Essex. And that means that they approach healthcare different. This means that they engage with us in different ways, and they also are vulnerable to different types of comorbidities. So what were the results? And probably I want to spend a bit more time. So this was the result for clustering analysis, and this is just reflecting in terms of deprivation, just to give you a feeling of what kind of communities we are talking about. And cluster 1 came as being the most deprived of the communities, and you can see them there in the map. For those of you that are a bit familiar with the MIT deciles from the ONS, probably doesn't come as a surprise. We also find that these ones were more likely to come after a referral. So they were very, very likely to come after a GP referral, not after, and were significantly less likely to come through the scanning program. So this tells that in these particular geographical areas of catching, the scanning program for some reason hasn't been able to connect with people, to bring people in. And this obviously has consequences in the outcomes, as we will see later on when we start to dive into the outcomes. The cluster 2 is also quite deprived, not as deprived. And here is where we start to deal with the nuisance of how deprivation is measured. And that's why we have here a bit more of the detail in terms of how deprivation is measured. You see that cluster number 2 is particularly deprived in terms of education, but it's not as deprived in terms of income, for example, as the first cluster is. And you see which areas are here. And we see these ones are more likely to, or also significantly less likely to come through a national screening program, and significantly more likely to come through a consultant referral, but not as much as the first one. But interesting here, we see a significant difference in terms of emergency admissions. So these people somehow manage to access better some of our services, but it's still actually they are the ones that are more prone to come to the emergency admissions. And when we dive into it, and sorry, I cannot show you all the details, but this plays a bit with age profiles and difference in age among populations. On the other side, we have the less deprived areas of our catching that luckily are the big part of our catching area. And there we see something very interesting in terms of who is getting the urgent referrals. And when we say urgent referrals, is people that has been upgraded, as you might probably know very well, from a normal 2-week pathway to an urgent pathway, so that they can be seen quicker and get treatment quicker. And we see that there is a interesting difference between those two segments of our population, with those actually living in the less deprived, the way less deprived, more wealthy areas of our catching, actually being more likely, significantly more likely to be upgraded to an urgent referral. And there is a discussion there whether that upgrade is a positive or a negative for the patient. It depends on the context in which it actually happens. Also told us a bit of how to identify that actually these clusters were very different in terms of the type of cancers that we were identifying people were likely to. So this one tells a bit of the story, but maybe for you it's actually easy to read this one, where we could see that breast cancer is significantly correlated to people, or significantly present in people from cluster 3 and cluster 2, while we have, for example, lung cancer being significantly higher among people from cluster 1, and skin cancer being significantly higher among people from cluster 2. So we see that despite the fact that they are, living, or we can describe them as being people from deprived areas, they are quite significantly different in terms of their behaviors, but also in terms of their needs of what kind of cancer do they have. We did something similar for when we look at our diagnosis. So the previous one was an analysis on the referrals. Then we wanted, well, actually, out of all those referrals, who are the ones that are being diagnosed with cancer? And we see that the algorithm, we use a slightly different one, but it reveals different clusters associated in slightly different ways, although you see some patterns in terms of first two are very deprived and the second two are a bit less deprived. And by the way, this is about Ipswich, so this is more focused on East Suffolk areas. You can see from the areas in the map. And a lot of these people, and this is why I was pointing out, people in deprived areas in East Suffolk, actually they live in urban areas very close to Ipswich, while people in deprived areas in Essex, actually they live in a more rural environment. And that obviously has significant differences in terms of the way access, transport, how long it takes to get to the hospital, how many GPs per capita. And we also saw, and I think this is probably more telling than when we look at referrals, that lung cancer are way higher among cluster 1, something that we probably know from national statistics, but is way higher anyway in our catching, and we can identify where these people live and who they are. So we are not just painting them as like people that live in deprived areas, but we actually can identify. So we go back to that map very quickly. We see that some of these areas are often associated with deprivation. However, we see that they are not as prompt as develop lung cancer as those in those areas there in the city center of the speech. So this is helping us to recognize what can we do. And if you could see that some of these cancers should be detected through our scanning programs, and the fact that they are not, and the fact that the people that is more likely to be diagnosed with these cancers are actually the people that is less likely to come to us through the scanning program is of a concern to us in acute. Finally, we keep diving into the problem, and here we use just multiple linear regression and multivariate regression analysis to see, well, once that we have these people, how good are we dealing with them? How good are we going through these 2-week pathways and the 62 days target? And some unfortunate but revealing insights from this analysis was that, if diagnosis was a key element on it, so if people if we managed to get people diagnosed in time, we were likely to meet the 62-day target. However, we also saw that, and you say each additional day, that we also saw that each day that we delay or that we were late to diagnose people, that it increased significantly by a factor of 3 times the likelihood that they would not meet their 62-day target. But going back to deprivation, I wanted to show you this. So we see that when we look at particular deprivation, we saw that there are particular GP practices, particularly ethnicity, particular location of the GP practice that was increasing the chances of people, things that probably you would think that they are not as or shouldn't be making a difference in whether people is likely to start treatment within 62 days, that was having a statistical impact on the targets. And this is, particular concern because, as I say, the fact that you're referred for practice, GP practice A or GP practice B shouldn't influence or shouldn't affect the chances that you have to be treated. So, to conclude, we obviously, I think we all know this deprivation has a clear impact on access and outcomes of healthcare. But I think when we talk about deprivation just with this general brush, sometimes we miss the nuances of the details. And I think machine learning, at least we found that machine learning really help you to get underneath the skin of those details and identify specific populations, specific groups of people that are at a disadvantage, and also help to flesh out the questions for clinical teams or executive teams and say like, well, it's not just that these people that live in this particular area because they live far from the hospital. There are, very interesting issues here. There are also these differences that shouldn't make a difference. Is why people that live in a particular ethnic group will have more chances to miss their target. But there's clearly something there in the way that they approach our services, in the way that we offer these services, that can be different to help them actually to be treated on time. And I think this is just the tip of the iceberg. So I'm going to be totally honest and very humble on this. So, I know that probably you have done very interesting or similar projects, but we just wanted to share a bit what we have done. Maybe inspire some of you, maybe inspire other of your colleagues, but also get out there and say, well, yeah, doing these very simple and very common techniques, you still can get lots of insights and reveal quite interesting picture for stakeholders in the hospital. And I think that's my deck to us. Thank you very much.